I'm a bit shorter, so I have to put this down. Okay. So, ladies and gentlemen, dear doctors and colleagues, good morning. I'm going to talk about sulfonylureas in the current practice of type 2 diabetes management, where I will try to answer the question of, are they all the same? Where I'll be summarizing a consensus from the Gulf Cooperation Council, the GCC countries advisory board on sulfonylureas. So this is my disclosure. As an introduction, we all know that there is a sustained and alarming increase in the global prevalence of diabetes from around 9.3% in the year 2019 to an expected 10.9% in the year 2045, accounting for around 700 million cases worldwide. And unfortunately, the prevalence of diabetes in GCC countries is among the highest in the world. And we all know that glucose control is the foundation of diabetes management, where most international guidelines recommend the use of metformin together with lifestyle changes as the first line of treatment in newly diagnosed type 2 diabetic patients. However, discrepancies between these guidelines on diabetes are mostly related to the recommendation of second-line agents. And despite the paradigm shift in these international guidelines, which recommend certain classes for secondary cardiac and renal protection, actually sulfonylureas are still a popular add-on treatment to metformin. And that's due to the extensive evidence of their efficacy and understanding of their benefits and risks as they have been in use for more than 60 years, and also due to their affordability and tolerability. And these characteristics actually allowed sulfonylurea to maintain their position in diabetes management even with the release of the newer and more expensive classes of glucose-lowering agents. In this presentation, I'm summarizing the present and future use of sulfonylureas such as gliclazide MR in the management of diabetes within GCC countries, where I'm presenting here a consensus from GCC countries advisory board that aim to fill the gap of the lack of local guidelines on sulfonylurea use. This consensus was conducted in the year 2020 and published in the year 2021. Where 12 regional experts across the GCC countries discussed the use of sulfonylurea in current practice, as you see their names here. And this consensus actually was based on previously conducted studies. This consensus was further endorsed by the Gulf Association of Endocrinology and Diabetes and Saudi Scientific Diabetes Society, Emirates Diabetes and Endocrine Society, and Bahrain Diabetes Society. So I'll be talking briefly about sulfonylureas and in particular gliclazide MR in terms of mechanism of action, long-term efficacy and safety, cardiovascular safety, renal benefits, hypoglycemia and Ramadan, and finally body weight gain. So in regards to mechanism of action, we know that sulfonylurea stimulate the release of insulin by the pancreatic beta cells, and that's by binding to the sulfonylurea receptors, and that will block the potassium channels and will lead to the influx of calcium to the cells, which will further promote insulin release. Actually, these receptors are also present in other cells like cardiac cells, muscle cells, smooth muscle cells. However, it has been found that gliclazide MR selectively and reversibly bind to these receptors in the pancreatic beta cell and not to other receptors that are found elsewhere, unlike other sulfonylureas that are less selective. And actually, after binding to the receptor, the restoration of the early insulin peak and the stronger reversible binding of gliclazide MR to beta cell receptors compared to other sulfonylureas that are not reversible, could be responsible for the reduced pancreatic stimulation, which translates into a reduced incidence of hypoglycemia. What about long-term efficacy and safety? Of course, long-term efficacy and safety are paramount when deciding on optimal treatment. The risks and benefits of sulfonylureas are well documented, given their established history. And that was proved by the ADVANCE trial, which evaluated the effect of intensive glucose control, defined as the use of gliclazide MR plus other drugs as required to achieve HbA1c of less than 6.5% versus standard glucose control on major macrovascular and microvascular events. And what was learned from the ADVANCE trial was that tight glycemic control to less than 6.5 can be achieved safely and maintained for 5 years using a sulfonylurea-based regimen. It also showed that early tight control with the sulfonylurea-based regimen gave 14% reduction in microvascular events versus standard therapy. Another study called the CPRD, or Clinical Practice Research Data Link study, that compared the safety and efficacy of gliclazide MR versus a commonly used DPP-4 inhibitors, which is sitagliptin, as add-on treatment to metformin monotherapy in type 2 diabetic patients who were uncontrolled on metformin only. This was a retrospective observational study, a real-world study involving around 2,000 type 2 diabetic patients and treated for up to 9 years. The study showed that patients treated with gliclazide MR were 35% more likely to achieve target HbA1c of less than 7%. And as you see, that was as early as 3 months with similar durability and persistent of glycemic control for both agents, which again proves the efficacy of gliclazide MR. What about renal benefits? Several publications have confirmed renal benefits with gliclazide MR-based intensive treatment versus a standard therapy. Back to the ADVANCE trial I have mentioned, which showed a significant reduction in major microvascular events by 14%, and that was actually driven by, let me see, it's not working. And that was mainly driven by the reduction of worsening nephropathy, which were reduced by 21%. And actually, this result was demonstrated by the reduction of end-stage kidney disease by 65%, and reduction of new onset macroalbuminuria by 30%, and the reduction of new onset microalbuminuria by 9%. And not only in the ADVANCE trial, but also in the ADVANCE-ON trial, which is a post-trial follow-up for another 5 years that showed still a significant cumulative benefit with respect to end-stage renal disease, where there was a reduction of 46% of renal or end-stage renal disease, suggesting that renal protection persists longer after the trial. What about cardiovascular safety? With the concern about sulfonylureas cardiac safety, it has been proven that cardiovascular risk vary among different sulfonylurea agents. And it has been demonstrated that newer generation sulfonylureas may be considered cardiovascular safe and are not associated with an increased cardiovascular risk compared with older sulfonylureas. And that was shown again in the ADVANCE trial, where patients on gliclazide MR had no increased risk in cardiovascular events. And similarly, in the ADVANCE-ON trial, which is a follow-up trial, also there was no increase in cardiovascular risk. Another study, which is called the Carolina study, which is a cardiovascular outcome trial that compared the 3-point MACE, or 3-point major adverse cardiovascular events, in linagliptin, a DPP-4 inhibitor, versus glimepiride, and also showed similar rates of cardiovascular events with no increase in cardiovascular events for both medications. So we conclude here that among all sulfonylureas, gliclazide R is associated with the lowest risk of cardiovascular-related mortality, followed by glimepiride. This is a meta-analysis that assessed mortality and cardiovascular event risk among all sulfonylureas. It included 18 studies involving 167,000 patients, and it showed that gliclazide R followed by glimepiride were associated with lower risk of all-cause mortality and cardiovascular-related mortality compared to older sulfonylureas. What about hypoglycemia as a major concern with sulfonylureas, specifically with Ramadan fast? Here I'm showing you two studies, the first and the second study, where there was a comparison of the incidence of symptomatic hypoglycemia in patients treated with sitagliptin versus other sulfonylureas during Ramadan fast. And as you see here, gliclazide were associated with lower symptomatic hypoglycemia rates than other sulfonylureas that was similar to sitagliptin in the first study and even in better rates in the second study. And even in a more recent study that's called the BDER Ramadan study in the year 2020 that evaluated the effectiveness and safety of gliclazide R during Ramadan fast showed the incidence of symptomatic hypoglycemia of one event or more to be very low and around 2.2% only during Ramadan fast. And there was no severe hypoglycemia. So we conclude here that among sulfonylureas, gliclazide R poses the lowest risk of major hypoglycemia episode compared to other commonly used drugs. And even in the BDER Ramadan study, we conclude that patients on gliclazide R can maintain glycemic control with low risk of hypoglycemia while fasting Ramadan. A further sub-analysis, including the Middle East only of the BDER Ramadan study, showed very low rates of hypoglycemia of only 2.1% of symptomatic hypoglycemia among the patients, and only 0.6% that have confirmed hypoglycemia, and 0 severe hypoglycemia. Finally, talking about body weight gain. There is no evidence of body weight gain due to treatment with gliclazide R, which was again showed by the advanced trial, where participants already undergoing progressive titration of gliclazide had no body weight gain. And in the BDER Ramadan study, actually patients lost weight by around 0.5 kg from their baseline during Ramadan fast. So compared to other large trials, patients on gliclazide R in the advanced trial had 0 kg weight gain compared to other large trials with other interventions that showed significant weight gain. So here I come to the end of my talk with conclusion. The glucose lowering potency of newer generation sulfonylureas is similar to older sulfonylureas, but with an advantage of faster glycemic control and a lower incidence of adverse effects. And most endocrinologists in the region, including the experts in this therapeutic area who were involved in the present consensus, are fully aware that not all sulfonylurea drugs are the same and continue to prescribe sulfonylureas like gliclazide R as one of the top options for second-line treatment in patients without a non-cardiovascular and renal disease. And thank you for listening.